little bit about what we're going to do tonight is I generally prepare a webinar. And I usually have, a nice PowerPoint and all these slides. We're going to do that for a few slides because I always start with a little philosophy. But I'm just going to really throw up some cases tonight, and we're going to talk about them and see what we see and have some discussions about what we're seeing, what the postural listing is saying, maybe with a little bit of uh, um, module 1 stuff, module 2 stuff, and some biomechanics and stuff. We can't really talk as much chiropractic as the application, like, okay, let's adjust the person, but we're going to talk about some cases from a chiropractic point of view and what we see in see them as in kind of QSM visualization. Okay, so let's see if I can get going here. Here we go. So this is a picture of the way that I see the current health model. Okay. And that is somebody looks at an area, whatever expert and that may be, excuse me, and they, the devil's in the detail, and we look at it. We'll talk about the medical field for just a moment. If it's your shoulder, they would look at it as an MRI. Say you're having problems with your shoulder, and you would get an X-ray and you'd get an MRI, and the consequence of all of that is to say you have X-itis, you have this, and then this is the approach to do one thing, and that is to alleviate the symptom. That is really the approach, to alleviate the symptom, to suppress the symptom with pharmaceuticals. And if you can't suppress the system, and if it's a possibility, and there's a surgical answer. This little guy, my WebEx assistant went on again. Okay, so to go ahead and to alleviate some sort of suffering. Okay, and if and they examine that within nauseum down. Okay, so maybe we'll just leave the WebEx assistant on because she just keeps coming on. All right, so the so it doesn't matter where you go. If this was a headache, you would first go to to your primary healthcare provider, and then maybe you would end up at a neurologist. Okay, or then maybe you would end up at a cancer doctor or an eye doctor or an ear doctor for an infection in the ear, or you know what it was, it's really a toothache, so you got to go to a dentist, and then he doesn't send you to a dent. It's not a tooth, it's a root canal, and it's not a root canal, it's actually an impacted wisdom tooth, so now you got to go to an oral surgeon. Okay, you get my point. Okay, so if it's a foot, then it's the podiatrist, to the orthopedist, to this, to this, to this. And what happens is everybody in the medical field has their own brick that they analyze. Okay? Is that a fair statement? Does everybody see that for the most part?
Yep.
Yeah, you go where you go. You got a problem with this, you go to that guy. Okay? You start general and they start putting you into the funnel. Okay? And it works, obviously, to some extent. Okay, whatever that may be. It's not my model. I don't agree with it. I don't engage in it. Okay, but would everybody here agree that chiropractic is different? Who would say that? Nobody?
Yes,
I
I
would.
would say that.
You would? And who, Jenny, would you say that? Who's Jenny? Jenny, you there? Okay. All right. So here's the thing.
Yes.
This is the funny thing, okay? Because I'm going to ask you this question. So as chiropractors, you get to go to another chiropractor, And in the top left picture, you got an upper cervical guy. He's going to take a nasium vertex and he's going to tell you that you're an atlas that's displaced a certain plane line. There's a laterality between your head and your atlas. It creates a subluxation in your atlas subluxation complex area, and it puts pressure on your brainstem, and it affects the whole deal, right? And that's got to get taken care of. So you got to do that. And if you go to the next guy, who's a different guy, he's going to look more at your pelvis and the angles between the bones and a local level and measure it, and that would be your Gonstead friend, okay? But if you go to a functional neurology chiropractor, okay, that's a specialty that aids you in, I'm trying to read this a little bit better. I'm going to move this over. It's a specialty that aids in diagnosing and rehabilitating simple and complex neurologic conditions without pharmaceuticals or surgery. Okay, I didn't think we were able to diagnose anything except the subluxation as a chiropractor. So that's not even a bony model, which chiropractic, just in its word, in its language, in the letters of its word, its Greek, is by hand. So the next person, though, has a picture, and that's in the bottom left, and he says, hey, you know what? You used to have this curve, but now you have that curve. And you go to the other guy, and he measures a couple things, and he says, your head's going forward, your torso's doing this, and your pelvis is doing that. And you go to the next guy, and he says, hey, I use a Titron or a subluxation station or some type of heat device, and you know what? You've got functional issues, and even though I'm a structure guy, you've got functional problems, okay? And these things are lighting up, and it's all in your spine, okay? And if you go to a class and they're teaching you about how to evaluate a subluxation, it says you must find a system that works for you, not for the patient. It should work for you. An understanding of the human body, okay, and your understanding of the human body, okay. I'm not really sure what that means because there's anatomy and physiology. You could use a dual probe, a static palpation, motion palpation, X-ray, Titron, myovision, leg checks, whatever you choose in chiropractic, your post-adjustment findings should be better than your pre-adjustment findings. That's our field. So I don't believe that we are any different than anybody else, except that our philosophy is one of vitalism and one of inherent taking care of the body and doing no harm. Okay? But our evaluation, our science is far less than medicine because I was a master of the upper cervical world and I drew 3 lines on an X-ray of the head and the neck and 2 lines on a vertex. And 5 lines represented a body for me. And I was the most specific guy. Okay. I know that's a tough conversation. I don't know if I really planned on saying it that way, but it's it's not what's even um, the fair to choice right now in the biomechanics model and the biostructure model. The biostructure model out there right now doesn't resemble anything that any of this stuff is doing right here on this here. So I know we're vitalists in the heart. I'm the vitalist in the heart for sure. And I still do things that actually, with data, look at the body as pieces and parts. Okay. All right. But as a vitalist, we should look at it as a whole. Okay. And to do that, what is really cool is the current model is saying that the human body is tensegral, meaning it's a balloon. Okay, it's a balloon system, and the way I describe it to my patients is when I show them an X-ray, I said, listen, I get them oriented. I said, but the bone in here, you see how this bone is bending and your spine is bending? I said, that's not really the problem because the spine is not really the bending problem here. It's imagine this thing is a big balloon, and all of a sudden you start letting air out of the balloon, and the balloon with a bone system inside, all of a sudden starts collapsing down, okay, and squashing down. And that's what we see. And the great thing about the bony system is we actually can start, looking inside and we can see the contour of the human body. Okay. And so we'll get to that in just a moment. But the current tensegral model right now is saying that the human body is a tensegral system, and it's expanding system. And I tend to agree with that, but I agree with that in a much more, I see it a little bit more definitively. And that is, we are a balloon system from really the pelvic floor, okay, right into the, right here, boom, right there. And the balloon system goes up, and it 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 ends right there at C1. Okay? So really the pelvic floor to C1 is this balloon system. And if you think about it and you look at the anatomy, you could see that's a cavity. It's a cavity from C0, okay, excuse me, C1 all the way down to the pelvic floor. Okay? There's a space inside where stuff sits. The organs sit in there and stuff like that sit in there. Yeah, it's got a kind of a flexible rod inside it, but that balloon system is expanding and upward and open there, okay? And the head is not that way. Okay, the head is not that way. The head is a hard shell with a piece of skin on it. So even though it's hollow, it's not like a balloon system. Why? Try to push on your head. It doesn't squeeze in. It's hard. Okay, so it's different. Go push in on your belly. Okay, push in on push in on areas where you don't have your rib cage, because the rib cage kind of supports that area, but the balloon system give us form. But up above it into the clavicle, all into that area, and up into the neck is a hollow system all the way down into the groin and especially into the abdomen. That's all cavity area. And then below that is different. The legs are different. They're like basically two by fours, okay, that have been wound together so that when they bend, like say you do a squat, that the way that the ligaments are set up, that it naturally springs you upwards. So you go down, okay, you bounce down, and the way the tendons do, they're wrapped in the front and they pop you back up because it's natural for the leg to be out, okay, not completely out, but when you bend it and let go, it springs out naturally. So they're like these two natural springs, okay, and you have this balloon system, and then you have this hard deal on top, okay. So it's not really a completely tensegral system, but it behaves from the neck all the way down into the pelvis like a balloon system, okay? And it should be expanded and all kinds of good stuff, and the body sits up on top, and it's open, and it's inflated, and it's bouncing along, okay? And that's really what it does. And then it gets in trouble and it has damage. All right. And um, it damages the tensegral system, and it like puts little holes in that system, and it's like a balloon with a hole in it, and it starts losing air and over time. So over time, things start breaking down, breaking down, breaking down, and we see the pictures of that every single day. And these are the people that we're going to, if we get a chance, if we have enough time, I mean, it's already 20 after, if we have enough time, uh, is kind of just look at some of these people and see if we can have a bigger, deeper understanding to help people, okay, and what we're really trying to do, okay, as chiropractors. It's a great question. So these are all my patients, and they're all patients that have been with me um, pretty much for a short period of time. There's two people in here. One person that I just started back. I hadn't seen her for a couple of years, and there's a person in here that's been in here and got everything that he wanted. And after his care plan was up, I haven't seen him, but I will see him. Okay, again, because I see his wife, and that's just the way it works. So let's have a little conversation. Okay, so you remember this picture? Everybody sees this picture. So what we're going to do is actually, after we call the the guy to look at the shoulder, or the guy to look at my knee, or the guy to look at L5, or the guy to look at the atlas, and he told you that that little spot was in big trouble and that he was going to fix that one spot and make it perfect. Well, guess what? As you were walking away from the building, this is what you saw. And that's what these pictures represent, my friends. Every single one of them. So every single person that comes in has a story about how they got there. And I don't mean a verbal story. How they came into this world, you know, what innate and universal intelligence has for them to start, how they got yanked out, how they took care of themselves, how they were taken care of. And then you take the head, the neck, the shoulders, the spine, the pelvis, and the legs. Those are six stacked structures, and you put trauma into them, and guess what happens? The body starts modulating, gravity sets in, time sets in when we get weaker, and the nervous system does what? What does the nervous system do, my friends?
Modulates.
It modulates, and what else it does, and this is Brad. I'm going to teach you some stuff at Mod 3 that's going to shift your whole game like a monster mountain. Yeah,
Good.
like bigger than everything we've done. Okay, and what happens is I'm convinced it freaks out. Okay, and it locks up. And our purpose is to be able to look at every single person and say, how do I unlock that thing? Okay. Now, this lady right here with her spine bending over like that, okay, does she look like that was the way it was supposed to be and that's the way it made? Is that just gravity pushing down on it? Okay. Why is that body even doing that in the first place? Right.
Compensation.
Well, how about it's freaking out and the whole body is afraid that it's going to fall over? Is that a fair statement? Is this going to fall? Is this person going to fall over if those muscles weren't there? What do you think the nervous system's doing there?
Freaking out.
Freaking out. Heck yeah. Okay, so what is the freak out system? The sympathetics, okay? So what happens is this thing starts going off center and it compensates, and at the same time, okay, the sympathetic system overrides the parasympathetic system. Okay, and the parasympathetic system is a system where we are sagittal plane and the frontal plane, and everything is balanced, and tensegrity is up, and the shoulders come back. Okay, I mean, think about that. If your shoulders are back and your arms are back, is that something of a position of freak out? Okay. All right, or what about if you roll your shoulders forward like this lady, bring your arms in? Which one is the fear mode? This picture right here, right? As you bring your shoulders in. So my contention is that a lot of the stuff that we're dealing with is the sympathetic nervous system that's being overloaded. And you've heard me use the word of we have a neuro lock, okay? And it's funny because, and that we free that and we open that and we expand that, okay? And the thing that happens, and our job is to really restore that parasympathetic dominance where the body can take a breath, the fascia can begin to relax, and the body no longer feels threatened, okay? Questions? Some new language there. And that's going to help us in the way that we look at things so that we can figure out how to help them better. And we'll talk about that. We will be experts at that after Mod 3. Experts. So let's talk about each case for a moment. Okay. And just to back up for a second, actually, let's just step forward for a second. Let's take a look at this case. Forget that what I did is I put some of the notes up. I've seen this person one time. Okay, I saw them on the 19th. What's today? 22? What's that? Tuesday? Monday? I saw them Monday. Okay. So, interesting conversation. Okay, while you're looking at it, forget the posture listing over here. Don't even look at that. I don't. I didn't want to put that up, for a very good reason. I don't. I want to talk about it, but I don't want you to look at that. I want you to look at, like, imagine this person is standing there in front of you. Okay, and and everyone on here is a chiropractic expert. You can't tell me you're not. Okay? Everyone, I don't know who all of you are, but you guys are graduated. You're doctors. You've been through anatomy, physiology, and there's a patient today that walked in the door, and you say, I'm going to help you. I'm giving you a reality check right now. Okay? And I have some questions for you. I got some questions for you. Okay? What do you see, and what is it that you are going to tell the person that you're going to do for them with this? Are you going to change that? Are you going to tell them you're going to make them feel better? Are you going to tell them that you're a chiropractor and you know the answer to that? And if that's the question, then what do you see that's not correct? Well, you can't just say the hip's not correct and look at that spine bending and then that shoulder's correcting. I told you this is going to be a night where I'm asking you questions. What are you going to say? Oh, because you're the expert. Is that what's not normal here? Is that pelvis normal, but that shoulder is not normal? Is If the spine is leaning to the left, should the shoulder be low on the right? Tough questions. You see, I can look at this picture and I could tell you what I know. Okay? I could tell you what I know. Um, I could tell you that I look at the pelvis and I look at the shoulders. And if you look at the pelvic angle, it may dip a little bit low on the right, but it's dipping significantly more on the right on the shoulders. I know that's not right. That's not normal compensation. Okay? I can look at the spine and not just go as a chiropractor and look at it and go, wow, it's leaning, but to know from a tensegral biomechanics of the human body and what's normal, and with that pelvis, what should that spine be doing, to tell you that it's not normal. Okay? What else can I tell you? What else can you tell me?
The
Brad,
head
what
is
do you
going to
notice?
that head's going the head's going to the right.
Yeah, I called the head just square, but you could call it going to the right. But the idea is that it looks like it's definitely more balanced than the shoulder, isn't it?
Yes.
Yeah. So why would you call it right? That would muddle things for you, wouldn't it? It looks pretty clear. Look at the orbits. Can you blow it up? I could blow it
No,
up a
but I
little
see
bit.
what you're saying.
Yeah. So look at this is I know nobody wants to hear these questions, but I put questions up on the doctors forum, and I'm asking chiropractors what they would do with it. Okay, and I'm not getting answers. Yet you're giving answers in your office. And okay, so I mean, what are you going to tell the person? What are you going to do for them? What is your plan? I mean, you're going to adjust them. Okay, I got it. But what do you expect to change? What do you want to see change first? What do you need to change? What's the system? Okay? What's the goal? Okay? How are you going to do that? And then how are you going to learn and know if that's doing well? Okay? Structure function. Okay, and you can't say function's better because that's a bad answer. Because if you're a function testing doctor, I could tell you the guy before he has a heart attack and dies, his heart is working. It's a crappy way. The second before you feel that you need a massive root canal because your tooth is killing you is a fine line between a quarter second ago. Function is bull if you're testing it as a chiropractor in structure. It's baloney. Of course, you want function to work well. I'm not saying it shouldn't. Okay, but the way through function is structure. And if you have good structure, you have good function. If you have good function, it doesn't mean you have good structure, though. Okay? All right, so here's a lady that I'll tell you the story on her. And she was a patient of mine a couple years ago. Now, if you look at her face, do you notice all the work that's up there? She's had multiple surgeries for TMJ and breathing issues, sinus surgery, eye surgery. She's had multiple appliances and TMJ work and all kinds of stuff. It's you can't even count it. Okay, and she left me, and has just went on to pursue other things. And she came in because her back was bothering her. Okay, and she called up the office and wanted to get adjusted because her back was bothering her. Okay. If you notice, here's my notes. I mean, big notes, right QL paid or whatever I wrote down. It's not on my screen right now. I'm just looking at the x-ray. And she was crying and said, I need to speak to Dr. Friedman, okay? Because I don't want to have x-rays. I've had too many x-rays. And when I called up the phone and I spoke to her, I said, look at this. First of all, I'm very close with all my patients, okay? And they know me just like I'm telling you what I'm telling you straight up, okay? And I said to her, look, I have a standard of care, and I'm not going to circumvent that standard of care. If you want to come back in here, I'm going to give you the best care. And when we get done, you will realize that I will have learned so much and you have learned so much and you will see the importance of what I do and why you're having trouble and still having trouble after you just told me that you just had your nose bored out. Okay. And still having breathing trouble. Okay. So she came into the office. She was crying on the phone with me, didn't want to do it. Called my front office about 4 times, was pissed that she couldn't come in and just get an adjustment. And I told her she needed to be restarted as a new patient. And she came in, okay, for her right QL pain. That's it. And I spoke to her yesterday, and the last thing she said to me is, I'm so happy we took those pictures because I really see what's going on and why I'm having trouble up top. Okay, and it's not really just the pictures. It's part of it is the ability to communicate why people are having trouble, why they're having trouble from a point of view that they can see it. And X-rays just happen to be a good way to do that. Okay, a posture IQ is only great for one thing, me. It's great for me because it tells me what I'm doing. Okay, and I can't work without either of these things at the level that I want to work at. Okay, I could work with a posture IQ probably more, but I'm going to show you a patient tonight that I had. It was the X-ray that gave me the inside scoop. Okay, so X-rays allow me to see inside and communicate with the patient and verify that I'm really making the right choice with the posture IQ because I'm seeing inside. But the data that I have goes ahead and allows me to see the changes that I make. Okay, so this lady has a posture listing. I'm going to look at it a little bit bigger here. I'll try to just spend about 10 minutes on each one of these. Okay, the first one will be a little more. So she's got a posture. She's got a posture listing right here, and it's right, left 3, A1, A3, R dash dash. And in English, that means her pelvis is low on the right, her spine is leaning to the right. Okay, her weight is on the left. I could probably argue, looking at that picture, that her spine is over on the left-hand side. Okay. Um, her weight was on the left. She's an anterior 1, anterior 3. Her shoulders low on the right, and the neck and head are kind of vertical. Okay. We could have a conversation of what we see, and maybe that's a little here. That's maybe not perfect here or there, but on the posture IQ, that's what I saw, and what it from a perspective of the first visit, it's not going to make a difference of how I'm going to adjust her. Why? Because I adjust the weight last on a second visit, and you could see that I adjusted her. The release sequence was right, left. All right. This conversation is not going to be about tonight. Well, on the right side, when I had her upright, what the bend point was and where I adjusted her on the left side. I will tell you this, that C0 through C7, everything, all the fascia comes up into that area, and that whole area is like a can, like a can of peas, a can of tomatoes, whatever, and that neck just rolls, and that head has a big weight on it, and you can turn this thing and roll this thing through an adjustment, boom, 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 and start stretching lines, stretching lines. If I was behind them, I'd pull stuff from the back, and I look at this posture listing and this postural wave, and each side has a optimal place where all the insertions come into that I've now recognized. And if you release those areas and then release the rest of the cervicals to follow, and everything's moving, guess what you've done? You've unlocked the sympathetic nervous system, and the person then has an ability to open, reset, expand, and gets a fighting chance of the parasympathetic and breathing, and the thing starts to open and expand more and more and more. And the whole kind of sympathetic overload and dominance starts going away. Okay. So generally, and I don't know why I did this, I probably left it on the card, is a lot of times I write down what happened when I adjusted her on the right, and then what happens when I adjust it on the left. And that's why I learned that. Now, on the next adjustment, would anybody like to have even a small conversation of what do you think that I would, just looking at this? Because I can have a conversation from another way of what I would do for this. Okay. And if you just looked at it, because this is more of a mod 2+3 question. Okay. And if you just looked at it, where does it look like the kind of the building is falling over? If the pelvis is earth, and the spine and the shoulders and the pelvis and are falling over to certain sides and so forth, what does it look like it's doing, guys?
Left.
Yeah, it looks like
Thoracic
it's
cage
falling over
falling.
to the left, right?
Correct.
Okay, so I can have a discussion and say, you know what? I could come in on that left side of that neck and try to release that tension that's holding that translation off to the left. Can you see that? Because I'm looking for muscle contraction. I'm looking for short fascia that is not just falling down, but is also in contraction. And we can see that the spine looks like it's getting pulled over to the left-hand side. It looks like it's falling a bit, doesn't it, that way, right? And that's where that weight comes from. Yes? You guys see
Yes.
that? Some of you see that,
Yes.
yes? All right,
Yes.
good. All right. And then what else do you see, though? So if the spine is leaning left, what happens to the shoulder?
It's going to the right.
Okay, so it's going to the right. So let me ask you another question, Brad. What do you mean it's going to the right? It doesn't look like it's going to the right. It looks like it's falling down on the right. It's going lower down on the right. It's not going right.
Correct.
Is that correct?
To
Right, because the
compensate for the body
spine
going
moves
left.
translation, and it also can bend, but the shoulder drops too, right?
Yes.
Okay, so the shoulder is dropping on the right-hand side. So why is it dropping, Brad?
To compensate for what's going left.
Okay. And so how does it do that? So
Well,
what you're saying is it's the nervous system and muscles. That's what that is. Could it be gravity too? Could it be falling down after that happens? Say
yes,
yes,
but
Brad.
I look, yes.
Okay, good. So that could be a combination between contraction or sympathetics, muscle spasm, okay, and gravity. Fair?
Yes.
Okay. So you have two things that you see that may need help there. All right. And I could tell you that I could look at it and I could tell you that I don't know the answer to that of what it needs. Okay, what happens if you just popped it open on the right, okay, and release that there? Is it possible that it could go to center? Of course it could, right? Of course. Okay. What happens if I just released it on the left there? Okay, is it possible that it would straighten out that shoulder? Of course it could. Okay. Especially from a Tensegral system that wherever I touch somebody, and this is the coolest thing. I don't know who's on here, but wherever we touch somebody, it's not like we're just pushing it. It's a balloon system, and the way balloon systems react if you push into it, it's not like a chair that if I push it, it just goes away from me. This is a system that I can make come to me, go away from me, go anterior, posterior, release it right, release it left, no matter where I'm at. Okay. And what I try to determine is on every side that I'm on is where is every side that I'm on is what I try to determine, excuse me, is um, where is the best place on that side to release what I want to release, and does it need that? Okay. Now, here's the issue. If this was a perfectly healthy balloon, no matter where I pushed in, if you push into a balloon, push your finger into a balloon, everything comes to the balloon. But this has been damaged now, and it also has some bones in it. Okay. So it's not 100% tensegral. Okay. It just behaves tensegrally from C0 to down to that pelvic floor with this big counterweight on the top that we use to our advantage to like bend and stretch the fascia on the top and pull it and do that kind of stuff. We've been doing that forever in upper cervical work, okay? And just putting force into this thing and changing it. It's an amazing system. All right? Take a peek at that lateral. You see how it's just breaking down? She's just breaking down, big curve, right? You know, if you look at the A to P again, you will see different muscle symmetries on either side. I'm changing the view on my screen. It's not listening nicely. Sorry. So I can't see anything right now. But depending on what you're able to see and so forth, but you could see folds in the fascia and folds in the fascia. It's not just somebody that's got fat on them. You can have skinny little people and they got all these little folds on them. And the issue becomes that it's like a tire that's just collapsing. You could see, so uh, I'm having difficulty getting back to my, here we go. Okay, I got it. Very good. Okay, so we're going to move on. Any questions on case one? Again, I'm just talking little bits and pieces on each one. This lady just came in. I'm going to follow up with her, and I'm probably going to see where she is. I'll see if where she ended up. She posted out nicely. That's all I wanted to do. I ended up adjusting her on both sides. It lifted up nicely. We'll see where it's going to take me. Okay? But you don't know until you know. All right? So I tell my patients, this is what I do. I do something. Okay? I see how the body behaves. Within a minute or two, because I check them on the posture IQ, and then I see how they do a week later. And then over time, I watch what does the best release for them, gives them the most stability so we can get people as healthy as possible for as long as possible. Okay? All right, so this is a guy that came in and I haven't seen him. His wife comes in, she was just here last week, and I said, "Where's your husband?" He says he feels too good. He'll be back, though. Don't worry. That's what she said, all right? So here's a guy. You think he's in trouble? Take a look at his x-ray.
He's in trouble.
Yeah. Now, do you think if I showed somebody, now listen, if an oncologist showed somebody that, that guy would be in care and wouldn't miss an appointment for the rest of his life. You know that? But he can't hear this. Okay. He's had one knee replacement. He came in with the other knee already saying he was going to get one. He's got all kinds of pain. He was in a lot of severe trouble, SI joint pain, blah, blah, blah. You could read it if you feel up to it. And we worked on him. Allie, Sean, and I worked on him. And this is where he started. He was I mean, you could just look at him. Okay. So look at his pelvis, look at his shoulders. Does it look like he's compensating, guys?
No, they're going the same way.
Same way. And look at the shoulder. It's collapsing down even further.
Right.
Look at the neck. Look at the head. You see it?
Mm-hmm.
He's falling apart.
He's screwed. Look at that L5, 4, 3. And guys, I remind you, that is not the bones. Okay, the problem is not the bones. See, the orthopedist will go bolting that together. That's the worst thing you could possibly do. I mean, unless the fascia is just failing. I got it. Okay, to stabilize it. But that guy is falling down, and that's a tire. I mean, look at that tire. It's collapsing down on itself, and it's riding on the right-hand side. Okay, he was only 14 pounds off the center. It looks like he'd be 50, doesn't it? But he's falling down on himself, not just sideways. You see it? That's really the biggest issue. His twist is 8 and 10. Everything's going to the right. Okay? So here's a guy. Here. So when I adjusted him on the left-hand side, the weight went from 14 to 19. And his rotation, 8 and 10, went to posterior 2, which is a -2, and an anterior 5. Okay? So the question becomes, does he need the left side? And if you just look at that, you go, well, it helped him. It brought the rotation of his pelvis down the half, and it knocked the rotation in his shoulders completely out. Okay? And you can then somebody could say, well, it counter twisted him. Well, that's not good. And I may say, well, that may be -2 and it just slingshotted off and it's really 0. We'll just have to see if that persists. Okay? After the first adjustment, okay, he came back on 4 or 5 days later. 5 days later, and he was 50% better. He's got some bilateral foot numbness because he's diabetic. He's got breathing issues upstairs. Unbelievable. Yeah. You know that expression, forgive them. I live with that every day for my own personal self. But look at this. Look at this. Look at what happened on his post. This is what I want to show you. So he went from an R14 to the next time he came in to right 35, P1, A5. So you're looking at the numbers. The configuration basically the same, except the heads was starting to turn back to the left. So what's happening here?
Body's opening up on the right.
So Brad, the guy went from 14 to 35. Is that
So
good?
no, but I'm looking at the rotations. That's better.
Okay. So Brad, you should really hold your guns with me sometimes. Okay?
Right.
So if I had a picture of, I have a plastic ruler in my office. And what I do is I press it down just like this here. Okay? And I say to my patients, I said, and I take it, I bend it out, imagine 14 pounds, and I push it down and I twist it. I don't make it a 4 and 10. I kind of say, okay, this is what's going on. Everything's leaning to the right. You're 14 pounds off and your shoulders, and you see it? I'm twisting it, okay? And when I twist it, I bend it down because that's really what that represents. I said, what I want to do is find the way that this thing springs out. Okay? I don't care if it goes out to the right. I don't care if it goes out to the left. I don't care if it goes straight to zero. Okay? But I got to get it out first. And so I tell them it's like a ball in a sand trap and it's driven down a foot. You don't just drive it through the sand, you got to bring it up. Okay? And that is my first and only purpose, is to free this thing and to do that. Did that happen pre to post or pre to pre, Brad? Say yes. Brad?
Yes, it bent right out.
It did. The rotations went from 8 and 10 basically to -1 and 5 and half. Okay? So he's going out to the right. That's okay. So what I'm going to do is, I said to myself, he's probably pretty decompressed right now. And guess what's another indicator that he's decompressed? The head that was jammed down there for some reason, the whole thing is just squashed in. I don't know. He had a concrete block hit him on the head, and the whole thing went kabam. Okay, and he's been jammed in that position. We popped it up. It sprung out, and now we're starting to see some what? Nervous system normality, where the head is starting to be able to bend back to the left. So I said, okay, I'm going to try to pop him open on the right-hand side and see if I can do that. And he went to a left 12, anterior 3P1. Yeah. And I could look at this and I could see that this guy's got a lot of trouble on the right-hand side. Not a bone out of place, not degeneration, not your curve, not heat, not functional neurology, not you got a leg discrepancy, not you got a scope, not you got a extremity, not you got a frozen shoulder, none of this. And all of this. All of that. Okay? And that's the language that we got to start talking about, guys, here. Is we got to be able to look at this, be able to create some data, say, okay, what's not normal? And we didn't even do this stuff, okay? It's too involved right now. That's what the classes are about. It's easy. It's actually, where are these numbers? And not just, 35 pounds is bad, but I've got letters representing where the body is tilting and what's down, and there's patterns that are normal and patterns that are not normal, and that's where it begins. You got to know when somebody's looking in front of you is where it's not normal. And we have not even defined that in chiropractic or anywhere in medicine of what is not normal for the traumatized body. I don't know how people speak in good conscience as a chiropractor once I'll tell you a funny story because I'm going to give you some Jewish guilt right now. Okay. I said to a rabbi, is a sin if you know it's a sin? He said, well, if you don't know, it's not the same magnitude. And you know what I said to him? I said, I'll see you later. He laughed. I didn't leave though. Okay. So now you know. Okay. Now you know. Okay. So now I want to know what you're going to do with this information and how you're going to get it so you can actually start helping these people at a better level. Okay. And have the equipment to do it. And I'm being rough tonight. I love it. Okay. Case 3. So this is a case that one of my best buddies, chiropractor, is having trouble with. Everybody's got a nemesis, okay? I got one too. Okay, I show her usually up at the, I don't usually at the modules. I even tell her she's my, my poster child. Okay, I said everybody knows you. Okay, so this is my friend's that has this here, and she came down to visit me, and I could tell you the same thing that I told you, that I'm going to see you for 4 days. I'm not here to stabilize you. I'm only here to learn maybe something that I could pass on that your body likes. Okay. And that really is the purpose, is that we have a pattern. Okay. We have a pattern. And I could tell you, I've got 1,500 people that have that pattern in my office, but none of them behave the same. Okay. None of them behave the same because there's a patient in there. So you have a patient of their what they've come with in nature, how they've nurtured themselves, and how they're gonna receive this. Okay, so it's a tough task, guys. Okay, but it's not so tough. All right. So anyway, she's got all kinds of trouble. Okay, and she's not happy about it. And she came in like this with this listing: right 12, P9, P7, RRL, just like we saw, similar to the other person where they had popped out. You could see it. Everything's leaning over to the right. You could see that there's obviously something is not integrated. Look at the pelvis and then look at the shoulder. Okay, is that flowing? That's not flowing. Something's not right. Okay, I mean the pelvis and the shoulders are not moving in a flowing way. Okay, you could see that, yes? So when you have this non-integration, people are in severe locks to protect themselves, that it actually creates a non-flowing misalignment, which create these patterns that are not normal. Okay, and it's our responsibility to try to figure out how to support that and to release that and support the patient. Okay, so I adjusted her first time, new patient mentality. Okay, guess what I did? I adjusted her left side up first, and look what happened. She went to a right 23. The rotation in her shoulder went to 0, and her pelvis went to 5. So what did I learn? Okay, when I say what did I learn, one shot. What did I learn right now? For now, it may not be true later, but for now, I mean, I got to get some information. What can I dig out of this? What do you see?
The way out is to the right.
Well, the way out is to the right, but I can give you another example. I could say to you, Brad, that I could be a little more detailed, and I could say that the way out is to the right for the shoulder rotation and maybe not for the pelvis. How's that?
Based on your post on the rotations.
Yeah, the 7
Okay.
went to a 5. I
Okay.
don't. Okay. So then when I adjusted her on the right, the weight went from 23 right. I'm bouncing here. This I made a note. Here's my left adjustment. Okay. This is what happened when the objective finding on the right. She went from right 23 after I adjusted her on the left, and then the shoulder kicked out to a 6, and the pelvis went to a -2. Now what did I learn? I'll tell you something funny. The doctor who's getting this patient, he's screwed because the patient's weak in 2 areas. I mean, it's almost like you can't win. You adjust them on the left, it knocks them over to the right, okay, and doesn't get that problem out in the low back. But then when you adjust them on the right, the shoulders freeze back up too. The pelvis is okay. So you got it. So which one's better? I don't know the answer to that, but I do know this. I do know that I got to do the left-hand side. That's what I would do. Okay. And actually, what I thought was with this person on the second day is I'm not going to do the left-hand side because maybe it responded that way because I adjusted it on the left-hand side first. I'm going to try the right-hand side. And that's what I did. So let's go to the second day. Okay. So this is where I adjusted her. This is where she started, right 12, P9, P7 with this configuration. Don't worry about configuration because it generally doesn't change, okay? And or it changes, later down the road. We want to get that rotation out of there and have this thing start going to vertical at some point, okay? Or we're going to have to help it. So what we're looking at is for the path out, all right? So I said, okay, I'm not really having a great idea. I said, it looks like it needs some left and it looks like it needs some right. So what I'm going to do is next time I'm doing something different. And if I just look at the x-ray, it's fair to say that the whole thing is failing or is in a lock over to the right-hand side. Is that fair? Can you see that? The weight's there. Everything is there. All the postural structures are there on the right-hand side. And what are the postural structures? The legs, the pelvis, the spine, and the shoulders. So the only thing that's not on the right-hand side is the head, and that's not postural. All right. So it's locked on that right-hand side. So I said, okay, I'm going to adjust it on the right-hand side. And it did not like that. I could say it blew out. How do I know? Because I put a dash and I went back to the left, okay? And then I went back to the right and I ended up at this. So I learned something for this doctor is that they need the left-hand side, okay? And I tested it the next day. They came and they saw me, left-hand side. And if you notice, we've gone from a 12, 9, 7, 10, 1, 5, 6, 6, 6. I told her 6, 6, 6. That's bad. Okay. Okay. And then what happens is I adjusted them, and then they did some functional work. And after they had some functional work, they started trying to remember. I think I had to go back in. Oh, that's what it was. I think I had to go. I went back in and adjusted her because she was stressing a little bit. And after the functional work, she ended up at a left 2, P3, P1. And I'm like, wow, this is awesome. Okay. She came in the next day, and this is where she was. That small R means nothing. It's just a typo. And she was at a 12, 4, and 9. Okay. I adjusted her left, right, and she went to 0, 1, and 3. So what's happening is this left right combination is working just fine, but she has like no stability. Fair? No? Anybody talking?
Yeah, so you do one side, it affects the other, then the other side affects. So that's what you say no
Yeah,
stability.
but
'Cause-
I'm seeing a trend that she's being put up nicely with both sides. She needs both sides.
Right.
Okay. And then when I did the right by itself, it went freaking off the chain, Brad. It went out to like right 32. It bounced out and it collapsed. I said, okay, I'm not doing the right side by itself anymore. Okay.
Yes.
Yeah, guys, I'm telling you that as chiropractors, we look at a bone out of place, especially in the upper cervical point of view, and we say, I'm going to push this bone there. I look at things in a different way. I look at it as a system that is going to show me the way out because I've tried forcing it. Believe me, I forced it, and it doesn't go by force. You have to release it up and out and allow it to spring out. And once you unlock it, it's made to do what it's supposed to do. Okay, better than we can do that, right? Our job is to do what? Is to be able to look at something, evaluate it in tensegral biomechanics as well as possible with some data, and figure out a predictable way to have it release on a consistent basis. Okay, and watch the numbers change so that you can actually create stability and give the body a chance instead of breaking down. It could start healing, changing the hairpin cycle. Okay. Questions? Okay. All right, last one. Okay, so who's this? Oh, this is a lady just started with me too. She started right at the end of February, March, April. She's in let's call her 7 weeks. 7 weeks. Um, she's a cool lady. She's very active, takes care of herself. Um, but she just, she's got stiffness in motion. She doesn't have any things like pending my back, this, that. I can't do this. I feel bad. She's just chronically stiff and feels like her motion is really limited. Okay. So take a look at her film and look at it. And if you could look, you see that left hip is low. And the body starts coming back to the right hand side, and it creates kind of almost a nice balance in her shoulders. It's still hanging down just a hair on the left hand side, maybe, but the head especially is still turning considerably right. You see it? It's like it's out of sequence. If the shoulders were bringing itself up that evenly, why is the head turning so much? The head is the only thing that doesn't lock. I think unless you have a cinder block, smash it down. It's very difficult to lock C0 on C1. It's a frictional it's frictional, if anything. It's a head that sits in a cup. It's not like a joint with facets and locking ability like that, you know? So it doesn't lock, it doesn't have an ability to really lock in that joint. So if the head is turning to the right, something is not happy left. And it's interesting, here's a lady that's just bopping around and feeling some stiffness, and these are her numbers. Okay? She's there's two patterns, and she has an aberrant type 2 pattern, okay, where the weight and the pelvis are on opposite sides. So she's got a left, left, right, left. And if it was a normal pattern, the head and neck would be going to the left. Okay, so everything goes to the left because the legs are going to the right. Okay, so this is an injury to the legs that get hit over to the right hand side, and you see what happens. That pelvis drops down on the left, and the body compensates, and it creates a V. Okay, for the legs going left to right and then the body going right to left. But what happens is that left-hand side is apparently locking down too much or failing and falling down. A combination of gravity and the sympathetics. How do I know that? Because the head's turning back the other way. The head would not turn back to the right if everything was honky-dory at the shoulder or the neck. Okay? And it doesn't look like the neck is bent over to the left. Can you see the difference in the musculature on the left trap to the right trap?
It's greater on the left side.
Yeah. So she's got right glute pain, guys. Anybody know why?
That lower right side.
Huh?
QL tension on the right side
Yeah, why is there QL tension on that right side?
because it's falling to the left.
You're the man. You're the man. Yeah. Yeah, you can see that tension is holding on there, right? Yeah. Okay, super. Looks like you're doing a super job there. Okay, it's holding on with dear life. Okay, so is that a cool thing that it's on that right hand side? Is that good? Is that bad? Is it more problematic?
Better because otherwise you really don't want compression, correct?
Yeah,
Compression's
yeah.
hard.
I mean, this one's a little funky. I tend to think. I tend to think I'm just going to stand up for a second. I just want to feel this one for a little bit. There you go. Okay, I got it. Yeah. Okay, so if you stand, if everybody has the ability to just stand up, rock your hips, stand up and rock your hips, on your ankles over to the right hand side. The left hip will drop, okay, and the left shoulder will drop. So swing your legs over to the right hand side, okay, and the left shoulder falls over and the left hip goes over. Everything should be going to the left to create balance. And what happens is you'll feel on that right-hand side, if you go far enough, that QL is in tension. It's pulling. It's elongating. So I'll tell you a cool thing, okay? Fascia does not like to be pulled apart. So when somebody tells you, okay, I'll tell you what I mean. Actually, I want to show you something. Actually, I'll show you on another film because this one's not going to be a good film. And then we'll finish this up and we'll be done in a few minutes here. Sorry, I know I'm going late. Here. Okay, this one's perfect. All right, so let's say this guy's got, okay, so here's the deal. This guy has right SI joint pain. So he's got right pain over here, okay? So one of these sides is in tension and the other side's in compression. So this side, okay, so imagine this is Earth, which is the pelvis, and the tree is falling over which way? It's falling over to the right, yes? Yes?
Yes.
There it is here. Look, I'm going to really exaggerate it. I don't know if you guys could even see that. Can you see that?
Yeah, we can
Yes.
see it. It's a yellow line.
So right here, all this stuff is holding that tree from falling over any further this way. Fair enough? So the left, if he had issues on the left-hand side, that is elongating, and that's a muscular issue. But he's got problems on the right-hand side. So he has, neurologic, what I would call, sciatica, so to speak. Okay? Where it's compression side, which is more problematic, and you could look at it and you could see he's in trouble there. Okay? So let's go back to this one. Okay? And the same idea is she's got issues over here on this right glute. And it's this right glute, okay, that's holding up this spine that's tilting off to this left-hand side. Okay? So she has a lower level problem. She has a muscle problem, okay, a fascial problem. Okay? So if she has tension over here on this right-hand side, because the body is leaning too far over to the left-hand side. How do we know that? Because we see the pelvis, the spine, the shoulders, all three of the four postural muscles are leaning over to the left. And how do I know that it's even a bigger problem than the right-hand side? Because the head is tilting to the right, and that's the final say-so, and it's saying, hey, Russ, this is a left-hand problem because the head is still compensating right. So I adjusted her how? I adjusted her on my first visit. Wait last. You'll see I always follow what I tell you is what I follow, whether I think it's right or wrong, but I learn. Okay, so here's her listing. Right 16, A17, A11. I adjusted her on the left, okay, and she went to a right 4, anterior 3, posterior 3. Okay? And then when I adjusted her on the right, okay, I don't know why I have it backwards, she went to a left 11, A4, A6. And that's probably where I left her. So what happened? When I adjusted her on the left-hand side, her weight decreased, her rotation in her shoulder decreased, and her pelvis cleared out, right? So I was like, cool, okay. So I just flipped her over and said, okay, can I get the rest of it out of there? And actually, the rotations kind of kicked up a little bit, but it went off to the other side. I left it alone. Something fishy there, fair? It's not just so pretty and everything's looking great. One of them did one thing, the second one did the second. I've got better rotations in the first release than I do in the second, but I got better weight than I do in the second one, okay? Better in the second one than I do in the first one. And rotations rule. So what I did next is I said, okay, I'm looking at this thing. I want to help support her. I'm just going to adjust her on the left-hand side. And she came in at a 13 and a 14 and a 6. Okay? So she originally started at 16, 17, 11. And she came in after I did, and she's 13, 14, 6. I wouldn't call that anything major, but things are moving in the right direction. Okay? This time I said I'm going to adjust her on the left-hand side. Why? Because all the postural muscles are on the left. The head is the indicator that is probably the primary failure. Okay? Because you get that. If you do, you get that. Great. Okay? And I adjusted her on the left-hand side, and she went to a right 4. Didn't go left side. And the rotations went to 8 and 5. And I left it alone. It felt good. There's nothing else for me to do. Okay, I don't want to go do what I just did last time. Okay, I want to figure it out. I got to be patient. She came in, and the rotations are kind of big again. Okay, and the weight is on the other side. So just by leaving it alone, all right, the weight went to the other side, and the rotations got bigger, though. So maybe the left-hand side, I started looking at this and I go, well, maybe the left-hand side isn't what you need, but I don't know that at all. So I said, okay, you know what? I'm going to go back to left-right this time because left kind of, I don't know if it's any better than the right. I went back to the left-hand side and look what I did. I checked out what the left-hand side did, okay? And it went from 3 pounds to 12 pounds, and the rotations went to A1 and P5. Okay, so the rotation in the shoulder went all the way down again, and the pelvis just decreased a little bit. Okay, I adjusted her on the right. This is what happened. Okay, it counter twisted. I went back to the left. Okay, and I left it there. Okay, and I said, okay, I'll see what happens. Anyway, long story short, I'm going through a path with this lady that came in for just some mild stiffness with some crazy numbers up top here, and I have found something completely different than what I thought in the beginning. And that is that not that she needs left right, okay, because it really, something was not helping her here. Okay, I found that the left was counter twisting her. And once I started adjusting her on the right hand side, okay, then I can't see it because my assistant is in the way. Get out of the way. Let's turn it off for a moment. Okay. So what I found is I adjusted her on the left, okay, on 3 visits ago, and she came in and she goes, I'm not feeling good. Okay. Gone left, right, left, left, right, left, right, left. See, guys, my life is not simple. I'm trying to figure out what the person likes, but I'm documenting it. Okay? I'm documenting it. Right, left. This is okay. These are what happened, afterwards. Here's what happened after the right. Here's what happened after the left. Here's what happens after the left only. Okay? Here's what happened after both of them. Okay, here's what happens after left only. And then I adjusted her only on the right-hand side, okay? Because I said to myself, something's not right here. The only thing I haven't done is adjusted her on the right-hand side, okay? The left side seems to be counter-rotating her, okay? Look at this. I adjusted her on the left-hand side here, just on April 6th, okay? I see people a week apart. I adjusted her on the left-hand side, and look where she came in at. Okay, she started at right 16, she's at right 12, and now she's counter rotating. So she's going the wrong way. So I said, okay, I'm going to adjust her on the right. And what happened? So I've never done it before. She went to right 22, A2, A1, and I left it alone. And guess what she came in? Great week from the last visit. I checked her. She was R7, P8, P3. No counter rotation. The shoulder rotation is more than half. The pelvic rotation is down about 70%, and the weight is more than half from the right release. Now, I can't look at that on the film. I can't look at that in the postural listing, but I can look at that because of my data. Now, tonight I showed you stuff on an X-ray that made it important, why I need a postural IQ, okay, and why I need an understanding of these numbers. And then you're ready to say, I'm ready to go ahead and learn where do I put my hands so that I can actually release this thing. Okay? So the equipment, the information, and then the ability to hit the ball. But you got to be able to learn the rules and what's normal, what's not normal, and what the person is doing and how they're behaving, because it doesn't matter what you think should happen. That pattern and how that got there, and this lady is in her 70s, okay? 70 years of story, and you're not going to look at this and know all the details of it and find the labyrinth and the path out.
Question.
Yeah.
Are you still through this whole process? Are you still thinking I have to find the way out, even though it might be changing?
Always.
Okay.
I always will have to find the way out. And I'm always looking for the better way. And what happens is things heal, that they change too, that it's like it's a living game all the time. It changes. Okay? It's like the doors are constantly sliding, and and the thing that helped you last week, because it's healed, it may not need that anymore. So I may have a person that's left, right, left, right, left, right, left, right, left, right. Okay, like Marcy did, that came to see me from the other chiropractor here, and I may find that she doesn't need that left down the road. Okay, because that left, and the reason she needs that left right there is because of that kink right there. That when we were going in right hand side, I can't turn this hour around. Let me see if I can draw it though. when we were going in on the right-hand side here. Oh. Whatever. When I was going in here on the right-hand side, okay, it was bending this over right here, this area right here. There's a kink right there. So it's just bending that over, and it's like a balloon. It was just bending over and springing out like a rule. You got me?
Yes.
That's why I need that left-hand side. Now, I could figure that out, but I could also then go see that, and I go, oh, I see that. But I don't just look at that and I go, they need the left-hand side. You know, I do stuff, and that's the way I learn.
Right.
Okay. So, you know, the game becomes who wants to be a chiropractor, man? Who wants to be the best chiropractor? You know, who wants to be their best? All right. Well, I got one spot left on Mod 3. If you haven't been to Mod 1 or Mod 2 for the past year, you can't come. Okay. But if you'd like to come, I got one spot open. And the cool thing about it is the technology of the adjustment that I will show you will be 100% different than the Mod 1-2 adjustment in many ways. Okay. And I'll show you a way that to give you your best ability to pop somebody open and actually start patients getting off the table on a regular basis and saying, that's different. I feel comfortable saying that at this point. Okay, unless I cut my arm off with a bandsaw while making a chair tomorrow.
Be careful.
Don't do that. Please don't do that.
Yeah, that's what I said to a lady today. She had her finger in the headpiece, and I was closing it. I said, "Move your finger. It's not okay to fix your posture, but you lose a finger in the process." You know. All right, guys, listen. I'm not being rough. I just don't. You know how when a patient comes in and and they just can't hear it. I just don't understand what's going on with the profession, that you look at these things and we could start having a big language and some great stuff, and it's right there. It's so available for you right now. Okay. So any questions? Appreciate y'all coming tonight.
Good stuff, Russell. Thanks.
Thank you. And I will speak to all of you soon. And I don't think I'm going to do a webinar. Well, we'll see if we'll do a webinar next. Okay, we'll see how these things go. They're kind of small, you know. It's tough putting it together. Okay. All right. Have a nice evening.
Thank you, Russell. Thanks for your effort.